Okay, I think I'm going to start as the sort of participant numbers are sort of leveling off now. So thank you all for attending. Delighted to have you here for our inaugural Digital SIG event. The theme is going to be about digital inclusion. We're going to have you here for the next 2 hours. We can't wait to have our 3 speakers who are going to be presenting. Before we sort of introduce our speakers, we'd just like to spend about 15 minutes of your time just letting you know about what the Digital Special Interest Group is. And in actual fact, many of you here won't be members of the Royal College of Psychiatry, so we should probably start off by saying what that is. And it's essentially a body of membership of psychiatrists who are mostly based in the UK, that we sort of pay membership fees to. In return, they give us sort of teaching, training, education, help maintain our standards, and they also give us this kind of space for which we can pursue our special interests, our kind of niche hobby interests. And recently, I think in November 2020, we sort of lobbied for and was allowed to have this new digital special interest group. And we're here now just to sort of to kick off with our first event and to tell you about what we're intending to be doing. Next slide. So yeah, so I'm David Rigby. I'm a trainee psychiatrist working in Surrey, and I've also got an interest in putting on sort of mental health and technology conferences. I sort of like video gaming a lot as well, and sort of interested in the effects of gaming on mental health and also effects of social media and mental health as well.
And hi, I'm Romayne. I'm co-chairing the SIG with David. I'm a clinical research fellow at King's at the Institute of Psychiatry and Neuroscience. And I'm also working part-time in the gaming disorder clinic as well. Very interested in technology. And as you can see from this photo, specifically VR and how that might help with the deliverance of kind of psychiatry going into the future. We also have quite a big committee as part of the SIG, so doctors from all sorts of training levels, junior doctors to consultants to chief information officers and researchers from all over the country. So we're really excited to kind of get going with the work that we want to do and tell you a little bit more about that. So I just put up this slide to show kind of what this special interest group is about. We're really, really interested in kind of upskilling all of us around kind of technology and mental health. We've all had to think digital no matter what speciality or what kind of work you do kind of this year really with the pandemic. So within the SIG, we're going to be kind of putting on educational opportunities like online events, publications, hackathons, working at getting medical students to consider kind of psychiatry as an innovative field going forward. We're going to be a platform for kind of research, so please do share any amazing research you're doing in the digital space. We're really interested in the effects of technology on mental health, but also kind of novel diagnostic and therapeutic developments. We want to build a good community, so thank you again for coming today, and hopefully one day we can maybe meet in person and have some social events. And the Royal College of Psychiatrists does have an informatics committee that will do a lot of things around kind of digital clinical practice, but we also want to highlight any sort of kind of best practice and make sure all psychiatrists can kind of think digital going forward.
Yeah, thank you, Romy. So I'm just going to spend just a few minutes just so we're going to be talking about digital inclusion this evening, but I just want to give you a flavour of the kinds of things that we will be covering through future events, through sort of publishing on our website. We'll give you all the details of this as we go along on our social media accounts and in newsletters that we're going to be publishing. I should also just at this point emphasize that to be a member of the SIG, the Special Interest Group, you sort of have to be a member of the Royal College. However, this is already relevant for everyone here who's attending, because we really want to be sort of really engaging with our not just our membership, but with the wider community and general public. So we'll be encouraging you to sort of contact us if you're sort of interested in what we're doing and if you want to sort of help us generate content. So some of the interesting things that are going on right now in psychiatry. So avatar therapy is probably something that's sort of relatively well known amongst psychiatrists, where essentially there's studies where people with auditory hallucinations I've had avatars created for them, as you can sort of see one of them there on the screen, that sort of interacts with the patient. And this sort of process has been shown to reduce the severity and frequency of auditory hallucinations. And this has actually been going on for a number of years now. Moving on to virtual reality, right now, you might think this is sort of futuristic, but virtual reality is being used in the treatment of OCD, PTSD, specific phobias as well, and paranoid ideation, so, you know, psychotic symptoms. And then also, this is a specific example of a study that's come out a year or two ago, fascinating study of a neurologist here in the UK, who has shown that virtual reality, to sort of by testing people's navigational abilities in VR, by essentially getting them to go from A to B to C. So you can see a screenshot here where the individual moves to point 1, that 1 will then disappear, then they have to move to point 2, then point 3. When they get to point 3, they're just told, move back to where you think point 1 is. And that simple test done in VR is better, according to that study, than any other standard cognitive assessment in diagnosing the early stages of Alzheimer's dementia. And what they're looking at now is whether or not that study can actually look at sort of preclinical, so people who will go on to get Alzheimer's dementia, and you cannot detect with any other cognitive testing. So this kind of stuff, it's fascinating stuff, is going on right now, and it's going to be even more important in the future. Social media is something that we really want to be talking a lot about in the SIG, sort of both perhaps positive and negative aspects. So you know, there is a sort of growing evidence base that social media use can be linked to mental health disorders, can be linked to self-harm, anorexia, and what have you. But there's also evidence that, you know, if it's used in the right way, that social media usage can actually help people feel more connected to each other, can actually improve mental well-being as well. And there's also specific social media platforms out there for people with mental health problems. So I'm just highlighting here the Big White Wall, where essentially it's a community, an online space for people with mental health difficulties to talk to each other, to share experiences, to help people through difficult times. And this is moderated 24/7 by mental health professionals. Gaming, so I should just highlight before talking about gaming, is there is also a separate committee called Gaming the Mind. It's a registered charity who also sort of part of the Royal College of Psychiatry, who specifically look at sort of gaming and mental health, who have been doing this sort of for longer and better than we have, but we do have several members of Gaming the Mind on our committee. But looking at the link between gaming and mental health problems, especially considering the sort of soon to be ICD-11 diagnosis of gaming disorder, but also looking at the positive effects that gaming can have upon mental health. Again, studies showing that it can improve mental well-being, improve hand-eye coordination. And I've put here a screenshot from a game called Hellblade, which is actually developed in line with a consultant psychiatrist, where the main protagonist is someone who experiences auditory hallucinations of both kind of like a positive and negative kind of variety, and is fairly well thought to be a fairly well authentic representation of what it might be like to have mental health problems.
And some of the other areas that we're interested in are things like the emerging field of psychoinformatics, and that's kind of using principles from computer science to be able to digitally phenotype, so look at people's live data from whether they're wearing smart watches or carrying around smartphones, to monitor things like sleep, maybe even what you're texting, if you're using smiley faces or not, and make some kind of inferences about what your mood might be like. I think hopefully George is on the call today. He wrote this amazing piece called A Day in the Life of a Psychiatrist in 2050, really thinking about how this emerging field of digital phenotyping is really going to be part of our everyday clinical practice. It's also worth thinking about other ways artificial intelligence is being used in mental health. We've seen thousands and thousands of apps being kind of released in kind of on the kind of app stores to do with wellness. And we're seeing evidence that young people are particularly preferring to text rather than speak to someone on the phone when they're having low mood or even suicidal ideation. So this is something that's a really, really important area for us to know about. There's an example here of Wobot, which is an app which uses artificial intelligence, so a chatbot, to deliver sort of CBT therapy to people in the comfort of their own home via chat on their mobile phone, which I think is very interesting. We also want to think about things like digital well-being. So we all hear kind of Zoom fatigue. Ironic, I know that we're talking about that right now on Zoom, but this is a real thing that's affecting lots of people. So this idea of digital, what can we do about that? We're hoping to put on some events with the Royal College later this year. And I think digital inclusion comes into that. And obviously we're going to talk about that for the rest of this evening. And that also kind of feeds into telepsychiatry. We've seen a complete shift in psychiatry and how we deliver many of our services, having to do them online at a time when people may need us most. So we want to make sure that we're kind of up to date with the best practices, that we can provide guides, that we can support people who are working, and especially our patients, with how they can use all of these digital technologies.
Okay, fantastic. So we're going to finish up shortly and hand over to one of our committee members, Mariana, who's going to be introducing our first speaker. But before we do, as I just said, I really want you to join the SIG if you can, if you're a member of the Royal College of Psychiatry. So we'll be posting the link to do that shortly. If you are, or if you're not a member of the SIG of the Royal College, please follow us on Twitter. We're still sort of still in our sort of babyhood of using Twitter, so we don't have that many followers as yet, but please come and follow us. We're tweeting as often as we can, and we've also got a website, again still in its baby stages, but sort of watch this space in the coming weeks. We put up a link there and we'll stick it into the chat as well. Also, look, if you've got like an idea, or you think you might want to write something for our newsletter, you're up to something interesting in the kind of spheres that we've been talking about, and think that we should be getting in touch with each other, you're working on a piece of research, you're a person with lived experience of mental health and you're working on some sort of digital project, anything along those lines, I just encourage you to drop me an email. My email address is there, and I'll stick that into the chat as well. We'd love to hear from you, and as I said, we really want to kind of engage with you as a membership, and it to be like a two-way process. Yes, okay, fantastic. So we'll now be handing over to Mariana, who's going to be introducing our first speaker. Thank you very much.
Well, thank you very much, Dave and Romy, for the introduction, and thank you all for attending our launch event. My name is Mariana Pinto Costa, and I'm the academic rep of the Digital SIG. And today I'm very pleased to introduce Jenny Haskey, who is the CEO of Citizens Online. They have been at the heart of over 50 digital inclusion projects since 2000, and they've built a cross-sector network of over 350 organizations. And today, Jenny will be talking on how Citizens Online helps to ensure the switch to online and it doesn't exclude people, and how the pandemic has affected digital inclusion. So in this talk today, all participants are welcome to write their questions in the chat, and Jenny will aim to respond at the end of her talk. So over to you, Jenny.
Thank you very much, Mariana, and thank you for welcoming me here tonight. And what a privilege it is to join you at your inaugural digital special interest group to talk about digital inclusion. I have a personal interest in mental health based on the many various charities that I've worked with over the years. And so it is absolutely fascinating to be here with you all. And I really appreciate it's a very warm, sunny, balmy evening out here tonight. And yes, Zoom fatigue is alive and well. So I appreciate how that is for you all. So Citizens Online formed 20 years ago. We're a small charity focused on ensuring that the benefits of the internet and digital technologies are available to everybody. So many of us take being online for granted, and everyone here tonight has successfully logged in. It's clear that during this last year, we've all mastered the art of Zoom, not to mention the now famed and well-rehearsed phrase, I'm pleased I didn't trip over it, but the "you're on mute" line. Equally, I'm sure, just like me, many of you are faced with a daily diary that sees you juggling multiple systems for video conferencing alone, be it Zoom, Teams, GoToMeeting, and the list goes on. But unfortunately, the statistics of those without access, skills, confidence, and the motivation to get online is really quite stark. Digital inclusion is so much more than getting people connected. Equipping our communities and organisations with essential digital skills can have a positive impact on people's social interactions, their health and well-being, which is what we're here to talk about tonight, employability and financial inclusion. Alongside internet access, the importance of ensuring people have the skills to easily navigate and engage in an increasingly digital world simply can't be underestimated. And it simply can't be assumed that everyone has this basic knowledge. So whilst we're here tonight and it's fascinating to hear you opening and talking about such transformative digital development in your area of expertise, we have to recognise that actually for so many they're excluded, and that's a step beyond. So I'm thrilled that you've started with the very basics of digital inclusion, because it is absolutely key to consider those that are included before you start on the journey. Last night, I attended a fascinating event by Zoom, of course, but the inventor of the World Wide Web, Sir Tim Berners-Lee, spoke about how the internet has developed since its inception in 1989, and I can't decide if that feels like a long time ago or simply yesterday. He also spoke about its future direction and how he believes it will move us forward. However, he was crystal clear that fundamentally access to the internet needs to be a basic human right. And sadly, there remains so much more work to be done worldwide by our governments, the tech industry, public and private organisations. And it falls to each of us to get there. It requires people working together to ensure that the inequalities lessen rather than deepens. So in the age of the pandemic, many of us will easily adjust to working and socialising through the internet, but not everyone. And COVID has absolutely shone a spotlight on digital poverty. People who do not have the means to get online, despite so many of our essential and non-essential services turning digital by default. There is some support out there, but it's simply not enough. So if we look at these basic stats that were from just last year, 16% of our population are unable to use the internet or their devices without assistance. 2/3 of those who are online haven't used the internet or digital apps and tools to manage their health. And just now you were talking about all of the apps that are there to help support our mental health. Well, 12% of the population can't open those apps. There was a survey for the Health Foundation last year that further illustrates this digital divide. And when asked whether you would download the COVID contact tracing app, 71% of people with a degree said they would download it. That fell to 38% amongst those with no formal qualifications. And 17% of those aged 65% or over reported that they didn't have a smartphone. So the most vulnerable in our society aren't able to access some of those parts and those elements that are there to protect us. There is this common belief that everyone is online, yet some sections of the population that are already at the highest risk of highest health inequalities are also most likely to be digitally excluded. And being digitally excluded in an increasingly digital world risks exacerbating those existing inequalities across our society. So if we look at those barriers a little bit more closely, motivation is one of the largest. Some people lack motivation or interest in digital technology, maybe because they've simply never used it before. As I say, so many of us here tonight, it's a part of our daily lives. But when you really start to think about it, there's so many who don't. People don't always see the internet as being for them. And motivation is one of the key barriers in being able to do more online. Over 1/3 of those who are offline say the internet simply doesn't interest me, and 48% of the digitally excluded say that nothing could motivate them to get online. Age remains the biggest indicator of whether an individual is online at a crucial time. And during this pandemic, when digital can turn isolation into inclusion, the behavioural data shows that only 7% of the over 70s are likely to have the capability to shop and manage their money online. And I heard recently about a couple who their pre-pandemic routine was to once a week go to their local cafe and dine out. And after the first lockdown, when the cafe reopened, the social distancing measures had moved managing the menu and taking orders to an app-based system. It meant the couple couldn't order a cup of coffee and a bite to eat. It stopped their norm. Without a smartphone, nor the skills to do this digital exclusion, just took away a simple little measure. We know that finances are a huge impact. The initial cost of purchasing equipment and software, as well as those ongoing costs for data and internet access, can also be the significant barriers. The most financially vulnerable are most likely than average to live in a mobile-only household, with around 1 in 10 of those people only having access to the internet via a mobile. And whilst we can do a lot on our smartphones, if you try and write a CV or fill in some complex forms, it simply becomes impossible. There's been well-publicised issues relating to the digital by default nature of universal credit, which has exacerbated when we consider the need to get online, to sign on, to apply for a job. Those visible barriers are endless. But then there's a hidden inequality when we consider all of those opportunities of sourcing cheaper deals for our heating or electricity or various networks. It's all online. So the people that can't financially afford to be online equally can't access those discounts. So in effect, we're setting those people up to fail when they don't have access. People may have physical or learning disabilities that simply mean that they need more support when using tech. Specific needs can make IT just more challenging. And when we remember that 1 in 12 people have some sort of disability, and then layer on that with a disability that are 4 times more likely to be offline, we again recognise the barriers and inequalities faced straight away. Sometimes it's not simply the cost associated with connectivity, but the lack of broadband. And whilst there are plans to improve this moving forward, we know that the government has announced some exciting developments in the coming years. It remains ever present today. And even with sufficient access, basic digital skills, that lack of confidence, that fear of the unknown, it can be a significant barrier to people getting online. And that's really difficult to tap into and fix often when it's not considered. And equally, some people simply can't read. It's easy to bluff your way through this with a face-to-face conversation, but you can't hide away from it when you're faced with a web form or to apply for work or social housing, particularly where English is an additional language, placing refugees and asylum seekers at a greater risk of being excluded. And so whilst we think of the many benefits of moving our operational and for yourselves, your clinical processes online, it's so vital that we consider these barriers that can contribute to individuals being excluded from accessing digital services. These tiny barriers that build up, that really deepen the inequalities. Whilst we think about our service users and our patients, it's also really important for us to recognise our workforce too. The need to keep pace with digital transformation across all settings has been a significant challenge for workforces across the country. And that was there prior to the pandemic. It's been exacerbated, and I think we've all felt that urge recently. But so it's really important that we constantly think that it's not just the people that we're trying to reach out to help with our services. We have to think about our colleagues. So again, so many of us are used to sitting at a computer and engaging. For many of our carers, they simply rely and have used a smartphone for that access. And so whilst the digital world continues to rapidly transform day by day, digital inclusion isn't a problem that will ever go away, sadly. And as a small but very agile charity, we work in a way that means we can support that pace of change and better equip our society. So at Citizens Online, we have a three-layered approach. We work with individuals to improve their essential and basic digital skills. As we know, people with digital skills feel less lonely, they have better employment opportunities, they earn more money, and have better long-term health outcomes, which is absolutely what we're concerned about here tonight. To do this, at Citizens Online, we have an army of digital champions, most of whom are volunteers, and they offer that face-to-face, personalised support. And the critical skill that we look for in a digital champion is not about having any technical knowledge. Often joke in the office about quite often I need some support navigating between a Mac and an Android piece of equipment. So it's not about that technical knowledge. It's about patience and it's about compassion to help somebody who is venturing into a whole new world to bravely take those first steps. Something that's critical to our work is working with organisations to embed inclusion as a part of that digital transformation. So building capacity and those local networks into digital transformation programmes are critical. Through this, we work to create a team of embedded digital champions. So these are people already working within those organisations that are focused and conscious of transforming their services online, but have already recognised, as you have tonight, that you simply can't move online without supporting and taking those people with you who require those basic digital skills. So within these organisations, we work with some staff and we give them all of the skills and the tools that they need to become digital champions so they can best support their customers, their patients, their service users, and make sure that they are delivering a much more personal, relevant approach. Identifying that somebody has a need to develop some basic digital skills won't be fixed by sending them on a 12-week course to get those skills. Whilst yes, we can see the value in that, the first step is about finding that hook and nurturing them in and onto that journey. And I absolutely see that this is something that is so vital for yourselves to consider tonight. We at Citizens Online quite often receive referrals from people where it's so evident that we're not the appropriate person to work directly with that individual. And what is best for us to do is to equip these people who are working with patients, or as I say, customers, a whole raft of people, and help them have confidence in how they can share and take somebody on that journey so that they can equally access those vital services online. Ultimately, it's about encouraging people and taking them on that journey, giving them that confidence. That's where we will see true achievement. Diverting somebody who we have already nurtured a relationship with and then saying, you need digital skills, go speak to these, we actually see that we won't achieve a successful outcome that way. So where staff are confident of their own digital skills, as well as being equipped with the tools to have that patience, to encourage and support those who are excluded, to identify and recognise those people who need support, then that's where we see the successful outcomes. And so hopefully by the end of this evening, you'll all be eager and keen to become the digital champions where you are, and hopefully you can sign up. As I say, we have lots of tools to help and support our proud and passionate digital champions. And lastly, a huge big part of our work is kind of being proud advocates of working collaboratively to tackle digital inclusion. No one organisation can fix this issue. It's about, as I mentioned before, it's about us all working together. It's about us all recognising that accessing the internet is a basic human right and how we make sure people can achieve that. So we recognise the value in multiple parties working together to ensure people to get the help and support that best suits their needs. No one way works for everybody. So typically what this partnership working sees us do is we'll establish a digital inclusion project with typically a lead public sector client, through which we'll aim to embed inclusion and accessibility within their digital transformation programme, ultimately improving the digital inclusion ecosystem across their locality that then touches across all of the organisations sector-wide. Each project that we work on is tailored to suit the needs of the client and the area. We undertake thorough research. We really look at that evidence base of what's already in place for digital inclusion in the area. We run heat mapping to really recognise the challenges, and we'll look to establish a partnership with a stable infrastructure for the future, so that we can build on that network of organisations and support that digital champion network to support the work. A great way to describe what this looks like is our project in Brighton and Hove called Digital Brighton and Hove. This was set up 5 years ago and has been heavily supported by the council, who are really engaged. And it's a collaborative and cross-sector partnership. We engage over 350 organisations, and we know that we touch the lives of every resident across the locality. We have a team on the ground running a tablet loan scheme, working one-to-one with users, often who are so vulnerable in society, so homeless charities, organisations such as Age UK, and we receive referrals from different organisations engaging that varied cross-section of those who are most vulnerable in our society. Traditionally, our digital inclusion worked closely through the libraries and community settings, which has naturally evolved as the onset of the pandemic struck us. So with COVID, as well as the increase in demand on our work, we've had to rapidly transform and explore ways to continue delivering this work safely. So we've moved our face-to-face support over the phone. We've utilised video, continuing delivering this work safely. We'll use video call and conferencing, screen sharing, remote access tools. But again, something that's so critical in this is building that confidence and taking people on that journey. If you're already nervous about what this new world looks like, you need your hand holding along the way. We made sure that our digital champions that were already working with a number of people in the area actually proactively checked in and encouraged their learners and reinforced the need to be really patient with everybody. In Brighton, the waiting list for our tablet loan scheme significantly increased during the pandemic. Yet on top of this, there was a collaborative approach to contact those that were shielding and recognised as vulnerable across the locality. We contacted them and asked the simple question, can you get online? And this created a vital triage point that was so essential to identifying digital inclusion needs when most critical information was being pushed online. A particular frustration of the national efforts at the start of the first lockdown was a real blind spot on government messaging that repeatedly diverted people online. You'll probably recall receiving that letter from the Prime Minister sent to every household as we moved into lockdown. What you probably didn't appreciate is that the letter diverted people to the website. There was no other way to access information if you weren't able to log on to that website. And subsequently, we saw the daily briefings start to direct people for learning more about the rules within their locality to access that information online. So again, this is a crystal clear reminder of just how easy it is to overlook those who are digitally excluded. And perhaps this is a prompt for you tonight to check through your simple materials and just ensure that your services aren't merely focused online. I happen to pick up leaflets as they come through my door and collect the ones that just don't have a means of contact other than via an app or a website. It's so overlooked, it's so simple, and it's because people simply aren't aware of this digital divide. A further measure that we took as a direct response of a pandemic has been our free phone helpline, and something that whilst we can't wait to get back to delivering face-to-face support, we've also recognised that actually this is a really valuable tool to maintain post-pandemic. It's the only free helpline in the UK that's accessible to all, and we don't only encourage learners to contact us. Again, if you're helping someone to get online, we can help guide you through that process. We can give you access to courses and tips on how you can do this. So it really is, it was an instant response to the pandemic, but we learned that actually it's a vital tool as we move forward. And finally, something that I really wanted to flag up this evening for you all is privacy. And it's important to think of this in two ways. Firstly, as this stat that I've shared shows, people who don't use the internet are really concerned about privacy and security. And so alongside that motivation to get people online, we have to constantly reassure people that it is safe and secure. I was chatting to a colleague just last week about a patient, a mental health patient actually, who's been referred to us as they need to access online support. It's a vital utmost, yet they have significant concerns on starting that journey. So again, we're not necessarily best placed to help that person engage, but we can absolutely give the support to make sure that there's a successful outcome at the end of this. But furthermore, others may not have a private or a safe space within their home from which they can actually make contact. So not having that privacy, not having that safe space, it can further limit their ability to use digital mental health services, for instance. And privacy is critical, as I'm sure you all appreciate. 70% of tablet owners and 53% of smartphone or mobile phone owners stated that they use and rely on public Wi-Fi hotspots. So out of lockdown, many of these people actually relied on connectivity through their local libraries. So again, people are being forced into areas where they don't have that private space. So the support required is far greater than simply providing just the skills that I've talked about tonight, or a tablet or a laptop. It's thinking about those safe spaces. It's thinking about those environments. It's thinking about support equipment such as headphones or a stylus pen for those struggling with touchscreen technology. So again, getting people digitally included has to cover off so many areas. So some key takeaways that I'd really like you to consider tonight is, as I've just said, that privacy, the patience. You have so many amazing ways and innovative ways that you can take your services online, but you must take everybody with you. Obviously, you'll have the data and security concerns, and ensuring firstly that confidence is there across your workforce to enable confidence amongst your patients. So I guess to sum up, as our healthcare takes ambitious steps into operating in this digital world, there is a risk that those existing health inequalities could be further exacerbated throughout a growing divide of those who don't have the access, don't have the skills, and don't have the confidence to use digital products and digital services, and equally those who simply will not. There's practical steps that now need to be taken to increase digital inclusion, to avoid the evolution of a two-tier health system that advantages those already online and unintentionally leaves behind those without access, without the skills, and without the confidence to use your digital services. And that's why I'm so grateful that you have set up this special interest group to ensure that you're dedicating the time required, but ultimately you're also putting that inclusion right at the heart and embracing digital whilst ensuring that no one gets left behind. So with that, I hope that has given a good insight in terms of the work that we do to help people get digitally included. And I'll take some questions if there are some, Mariana.
Thank you very much, Jenny, for such an interesting presentation and for so many important points that you raised. I'd like to remind all of our participants that you can write your questions in the Q&A for Jenny. And I'll start by reading the first question to you, Jenny.
Okay.
So Paul Clayton is asked, do you think that support for digital devices and accessibility in general are equally as important? Example, got devices but no network.
Absolutely, and this is something that we're constantly talking about. There are a number of tablet loan schemes. I've mentioned we've set a number up around the country, as are many organisations. And some have fallen into the hurdle that they have instantly issued devices, but they've not thought about that wraparound support in helping people use the equipment and engage how they need to. And that's really the work that Citizens Online take to its heart, is the wraparound support that we can provide. So you can't do one without the other. We need more digital devices. I think anybody that tried to buy digital devices as the pandemic started will have absolutely struggled to get them. We are working with a fantastic organisation who are refurbishing equipment purposely so that we can reuse it. It is getting them to the right people, but it is then about making sure that we give them the tools to use them. We have seen circumstances where people have been given the devices and they just put them to one side and aren't using them because they're not being encouraged. Or like you say, the accessibility challenges, the lack of coverage in certain areas, certainly in rural areas. So one of our projects is in North Yorkshire, and a significant challenge is getting people online. So we're working with companies to look at devices to provide the accessibility that people need. So yes, SIM cards we are constantly buying and circulating and issuing around.
Thank you very much, Jenny. I'll move on to the next question from Marcus Tan, and he has said that you have raised good points, but his question is, has your research discovered what sort of groups would struggle with digital inclusion?
Absolutely, and I think this is a huge part of the challenge. Is the groups is so wide and diverse, and like I say, it is always those people who are vulnerable in our society that absolutely are excluded, and each group needs a different hook to get them to take to moving online. As I say, I spoke recently and somebody said, you know, what is that hook? How do you make somebody who says, I've no interest in getting online? How do we help them see that interest? So it's identifying those groups, and it's identifying the hooks, and it's working with them to build their confidence, and to really see how we can embrace and move them further and get them included. But it is across such a wide and diverse cross-section of society that we see.
Mm-hmm. Thank you, Jenny. So I'll move on to the next question from Barbara Arroyo, and she's asking, how do you measure behavior change when you support people getting online?
Absolutely, and this is where I say some of the challenges for us as an organisation and our digital champions is we don't already know, you know, we have the skills and the tools to provide people with the confidence, but if we don't know people's behaviour prior to trying to get them online, it's very difficult for us to measure that behavioural change. And that's where having embedded digital champions is really best placed. So somebody who can recognise behaviour and work best to tackle and support somebody, that's crystal clear. That's absolutely key for us. So embedded digital champions, certainly in your area of expertise, is going to be the important way to measure and understand that. You know, you'll recognise things that we and our volunteers or digital champions certainly aren't skilled to identify.
Thank you, Jenny. There are a few people who just wrote saying that your presentation was excellent, like Maria Kulopolo, but I think there's also a few questions in the chat which were not written in the Q&A, and I'm going to move briefly because we should move on soon, but there's someone asking how they can enroll to become a digital champion.
Absolutely. Please do visit our website, so www.citizensonline.org.uk. There's information there. As I said, we are absolutely always welcome people who want to be digital champions. We support you all the way. We give you all of the tools. So I will pop our website. I'll also pop my email address in the chat. So please, anybody who wants to, please do reach out and get in touch.
Okay, so the two last questions that I'm going to be asking you are from Pancho Javier, and he's asking, what should long-term mental health facilities do to support patients accessing technology? The digital divide is real and clear for all to see.
As I said, it is about, as you have done tonight, it's recognising it first and foremost for what it is. It's knowing your patients, it's recognizing those signs, and it's not necessarily deflecting it to somebody else. It's about, how do you embrace it? How do you make sure that you and your colleagues who actually don't see that the digital divide is there and is clear, it's making sure that everybody can see it and that everybody is best equipped. Like I say, during the pandemic, we all asked the questions: can you do your shopping? You know, can you get your medicine? Are you okay? Very few of us said, can you get online? Can you speak to a family member through video conferencing? You know, so it's asking those simple questions, and then it's building those steps to do it, which we're already doing because you're all here this evening.
Thank you. And finally, Dominic Stenning is asking you, why not digital leaders?
Absolutely. So we work with digital leaders as a huge part of our work in terms of that partnership. We deliver digital leadership training, and absolutely digital stems from the top. It's so critical that we all strive and we all lead the move to digital, and we don't let anybody, we ensure nobody's left behind. So absolutely, digital leadership is there in the heart of what we do.
Thank you very much, Jenny, for your time here with us. And thank you, everyone, for raising such interesting questions and for engaging in this discussion. We're now aiming to do break and be back at 7:30. So if you want to have a short time to have a drink or eat, this is the time for you to do it. But also in this Zoom platform, if you saw the name of someone that you want to reach out, you can also use this time to write a message to someone you saw and engage with. So thank you so much for joining us, and we will be back shortly around 7:30.
Good evening, everybody. Welcome back to what has already been a very interesting and exciting evening. So we move on to our next presentation, which is from Professor Alka Ahuja and Gemma Johns from Tele. Professor Alka Ahuja is a consultant child and adolescent psychiatrist who is also the clinical lead for the tertiary neurodevelopmental service at Aneurin Bevan Health Board in South Wales. She is also the financial officer of the child and adolescent faculty at the college, along with being the public education lead for the Royal College of Psychiatrists in Wales. She is the national clinical lead for the Welsh Government's Technology-Enabled Care Programme, or Tele. She helped establish NHS Wales's video consulting service. In March of the last year, as the pandemic unfolded, she was tasked with leading the rapid scaling up of this video consultation service. For successfully leading this mammoth task, she was honored with an MBE in the New Year's honors. Gemma Johns is the research and evaluation lead at Tele. She has interests in digital mental health as well as social policy, and she is pursuing a PhD in digital technology with Bristol University. So over to you both, Alka and Gemma.
Good evening, everybody. And Gemma and I'd like to share our journey, which has actually been a year last week, as to where we've come along in terms of telepsychiatry and what we hope the future holds. So we'll start with Kuch, which was connecting with telehealth to children in hospital. Kuch means hug in Welsh. And then moving on to COVID and the national program, talking a bit about the toolkit, and then sharing our experience of using video consultation in the mental health setting and how we move forward with this. I'll share a little video which is being premiered today. We haven't shared it so far. It literally is hot off the press. So it captures our journey and where we have been in the last year.
In March 2020, our small video...
Can you hear it?
Yes, Alka.
Consultation project based in the CAMS team in Gwent became an integral part of planning for a national emergency. Working with patients had to change in order to keep people safe from coronavirus. As doors were closed, laptops were opened, and barriers that had been so rigid previously fell away. We had to move fast to share our knowledge and build on it. Early on, we had no idea of the scale of what was to come. Perhaps we'd be back in our old office in a month, we thought. Not quite. Those first few weeks went by in a blur, developing the team, writing resources, hosting training, speaking to patients, clinicians, politicians, and the media. getting the message out there that support was available. We just needed people to adapt. And so many did. Video consulting, or VC, was quickly adopted across health boards, primary, secondary and community care settings, urban and rural communities. Assumptions about who would and wouldn't use VC were challenged as we gathered the data and increased our understanding. From the outset, we collected data. We knew that hearing from as many people as possible would be key to learn how video consultations were being used, how it felt for patients and professionals, and crucially, how it could be improved. The scale of that work and what we have already learned has meant that video consulting is now a beacon, with people approaching us from across the world to learn more. Awards and accolades have come our way, and whilst welcome and appreciated, the most important accolade has been hearing from patients about the positive difference VC has made in their lives over this last year, how it has offered connection and support in a time of isolation and uncertainty. Resources, guidance and advice can be found on our website. Research papers and how-to guides are being written and updated all the time. So we must keep rolling this out across further specialities and settings to increase awareness and improve patient experience, no matter what the current circumstances in the world may be. A year on, and we can't stop now. There is still so much to do, so much to learn, and so much to share.
So that captures what I'm going to share with you and what Gemma will build on. So we started Kuch in 2019, thinking of 2019, video appointments were quite novel. We were lucky to be funded by Health Foundation, and we were part of the Innovation for Improvement program, trialing video appointments to young people who were presenting with self-harm and severe eating disorders. We started with offering emergency assessments, but then soon realized that these young people were probably the most risky ones. So then moved quite quickly into community settings, offering follow-up appointments, medication reviews, working with GPs. We also started working with schools following a suicide in some of our local schools, which obviously increased the workload on the CAMS force. And we found that the post-vention clinics had a really good uptake. We did virtual groups. We did use Attend Anywhere, which was a platform that was already being used in the health board and was found to be a secure way of connecting. And I think that's something one needs to be mindful of. Security and safety are prime when we are doing anything remotely. We did training. We had identified good champions who supported the rollout, and also having a secure and safe setting, which was friendly for young people. And young people were quite open in sharing what they thought about the rooms they wanted, in terms of, we had lovely fairy lights. We made it very young person friendly, even though it was a remote setting. Again, one thing to emphasize, and probably is going to be the care message that we would want you to carry back home, is evaluation. Whatever you do, if you don't have evidence, there's not much that's going to support future embedding of this. So from day one, we captured baseline measures, looking at satisfaction among parent, carers, young people, professional and public. And not surprisingly, it was very high in terms of satisfaction rating. We also worked alongside a mathematical modeling department on developing super cool rotas, because we know, like any service in the country, there are always issues around demand and capacity. So it wasn't that doing this remotely or virtually was going to be any way quicker. Sometimes we know these appointments can take much longer if technology doesn't work, but also being mindful that some staff would have preference from seeing, working remotely. Some would want to see their patients face to face. And similarly, some patients would want to be seen face to face. So just making sure we had something that was equally balanced and was fair. Savings. This is a slide management love. It was in terms of clinical time, it was also in terms of travel time and the time spent on parking, which can always be a nightmare. And looking at carbon footprint and, how do we make it a more greener NHS and a more greener planet? Again, how do we make it sustainable? We developed a Kuch Kamri toolkit, which was a Ready, Steady, Set, Go toolkit, and that shared a lot of what we had learned during our rollout. But obviously, talking about this 2 years later, it's not teaching grandma how to suck eggs, but it's just sharing good practice. We had our successes. We obviously presented at various forums. And the toolkit was something that was endorsed by the Royal College, and it actually went through steps as to how you start from scratch in terms of setting up a service in mental health settings where you are offering video appointments. What we did was very much driven by our patients and families, and the young people were behind Kuch right from the start, because if they could communicate with their family and friends virtually, why can't they do it with their doctor and nurses and therapists? And they were the ones who were instrumental in designing the logo and setting up what we did in terms of guidance toolkits. But behind all this, as clinicians, we need to be very careful about safeguarding, the setting where we're doing it. If there are issues around suitability, we know that there are people who are high risk. We found that it worked very well with some of our young people with autism. But then again, there were some young people with autism who found quite difficult to link in. Eating disorders, we had, again, it's anecdotal, we found that our male eating disorder young people found it particularly difficult to engage virtually, and whether it was seeing themselves on a larger screen, but it worked equally well in some of the young people who revealed abuse for the first time. It's making it safe. It's doing a risk assessment, which one would do anyway face-to-face, maintaining all the good practice around confidentiality, consent, and having the right technical support. We were lucky because we worked and are still working with a fantastic team who had all the IT support and were ever willing to help us when needed. In fact, we had a 24/7 helpline. We joke about that. Having the right branding, and Kuch again became part of the video consulting program in Wales, capturing the satisfaction and using social media appropriately. And it's sharing good practice and again linking it with like-minded people. So I'm just sharing some of the visuals, which again, were part of the process mapping when you are thinking of setting up a service. And in some ways, we've come a long way because obviously people are using it, but sometimes it's just going back to basic principles and seeing how it fits in one service and what are the tasks that are needed, even in terms of educating or training the frontline and admin staff, the legal and ethical challenges. We still ask questions about, do you record these consultations? How do you document them? But I think it's very much like we don't record everything face-to-face, but we do document everything that happens face-to-face. Similarly, it would be done virtually, having the safety net measures in place, making sure that you would take all the precautions in making your room soundproof, putting a sign outside the door saying, consultation in progress so that people don't walk in. Similarly, on the other end, making sure the patient is comfortable, there's nobody hovering around or listening to the conversation. Along came COVID, and Gemma and I both got seconded to the national team, and Kuch was used as an exemplar to roll out video consulting across Wales. So we started with primary care, and again, as I mentioned, it's exactly coming up to a year. Within weeks, we rolled out to 90% of the practices, and as of date, we've had more than 15,000 consultations. Within weeks, the minister made an announcement to roll out to secondary care and all the community therapies or other specialities. And we are now over 50 specialities and about 138,000 consultations. Not surprisingly, care homes were next. And it was interesting listening to Jenny's talk because we partnered with Digital Communities Wales, being mindful of reaching out and providing the training and equipment to people who needed it most in some ways. So we worked alongside care homes, and I know my colleague Jane is there with us today, who's been working with dentistry, optometry, pharmacy, and again, I've spent 3 months last year doing a sabbatical working with school and seeing how we can provide remote care into schools. Some of the quotes at the bottom are from the feedback we've had. Groups is something that we were running for more than 5 years, and this involved working with speech and language therapists, dietitians, but also colleagues in education and local authorities, supporting parents and carers of children and young people with autism. But we know that with COVID, groups are not going to be the same. These groups will not happen in community centers and leisure centers for a long, long time. And there's going to be even greater demand for running mental health groups. We've already had groups for early intervention psychosis, perinatal groups that we are setting up, but also mindful that how do we evaluate and how do we make it accessible to everybody and not exclude the ones who cannot access digital groups. I'll hand over to Gemma at this stage, who'll talk more about the research and innovation.
Hi, everybody. Yes, so like Alka said, evaluation is core to anything that you roll out, especially within the NHS. So we've been doing this in Kutch, and we brought this over to the national programme, and we are doing both evaluation and research, because I think the NHS are very quick to do evaluation, but that has its points of how much that can do. So we follow a phased approach in Tech Cymru, which does early evaluation in phase 1, which is generally a survey data capture where we're measuring measures such as use and value, which includes satisfaction, suitability and acceptability. And then as we creep into phase 2, we sort of extend this from some learning, and as we've learned more about the participant group and the context we're working within, and start capturing more in-depth measures around benefits, challenges and sustainability. We do follow a quality improvement approach whilst we're running our evaluation, and we're also very keen to do a lot of qualitative work throughout our phases as well. As a qualitative researcher myself, I only believe in surveys up to a very small amount, so it's important, and so far we've had an amazing amount of qualitative capture, so it's been quite something. But then, like I said, we are very keen to make sure that research is embedded in text. So we have just started our phase 3 now on video consulting, and starting with some experiments. So in order to capture measures around efficacy and effectiveness. So we've just started with Cardiff University a randomized controlled trial. We're doing feasibility studies. We're also working with Cardiff University on a health economic analysis. So we're doing a wide range of studies at the moment to make sure we're pushing it out a lot further than what basic surveys can capture. So we've done our phase 1, that's been analysed and written up in the link below, and phase 2 is also being analysed at the moment and should be written up over the next couple of months. So we're constantly keeping our reports updated, and they're broken down by health board and specialities, so you can sort of dig in deep and find out how VCs work in specifically in a certain area. Next slide, please. So this is a bit of a quick overview of our findings at the moment, over the last year on video consulting here in Wales. So this is across 150,000 patient consultations, and we've had more than 40,000 research participants conducting on surveys, and almost now, I think, about 450 interviews. And we've also been doing focus groups recently, which we've run 15 different focus groups as well. So we're capturing data quite wide. We have noticed in the video consulting data that there are findings across demographic groups, social demographic groups, has remained consistent for over a year. So across age and gender, there has been this consistent uptake of video consulting regardless of age or gender. We've also realised that ethnicity and income, household income, is comparable to population data. So, and similarly for health conditions, there doesn't seem to be a whole lot of divide on the health condition type. So after a year of research and across every single part of Wales, there seems to be very little divide happening in these areas. And again, as well, across parts of Wales, urban and rural, yet another myth busted within VC in particular, in that it doesn't seem to make any difference where you live in Wales. Uptake and satisfaction and benefits and challenges all seem to be consistent across every single social demographic group and health condition and part of Wales. So my conclusion is there's no definitive conclusions. So who can and can't use VC, because it's, across 40,000 people, there doesn't seem to be a significant difference. So Other lovely areas that have come out as well across appointment types. This is very much across the board as well. First appointments almost representing 30%, follow-up appointments 30%, therapies 30%. So again, another myth busted when people were saying early doors that first appointments probably won't work, but follow-ups do. And again, it just seems quite consistent. VC has resulted in at least 85% of prevention of face-to-face needed. And now to date, I think there's about 31% of clinicians being able to work from home, which is benefiting themselves on their own home working balance as well. And then our favourite outcome, obviously, is the reduction in travel time cost and CO2. And the numbers, obviously, across the amount of consultations Tech Cymru have done now are quite significant. And it's been quite interesting because a patient, I can't see the figures because some comment hasn't popped up, so I can't see the figures, but approximately, as I remember, is about 53 minutes per patient per appointment is being saved. And on average for a clinician, it's about 90 minutes of travel and parking a day, which has been working out about £10 a day NHS expenses as well, what they would normally include on top of that. So overall, it's looking good. So, next slide, please. So here's a bit of an overview of just a very small handful of outputs that have come out in this last year, from awards to media coverage, to papers, to publications, you know, you name it, it's out there. This year has been quite a moment. So COVID within and VC in mental health specifically. So like I said, we've done 150,000 consultations across all specialities across all parts of Wales, but 21% of these consultations have been mental health related, which has been quite interesting because when we were back in CAMS, mental health was always kept coming back to us. Oh, it's the riskiest of the conditions to test this on. Maybe we need to test it somewhere else. But interestingly, COVID puts mental health in the testing ground, and it was kind of forced to give it a go. And I think giving it this go was all we ever wanted people to try, and it worked out well. 10% of our evaluation is also mental health, so any conclusions we're making are also, you know, very heavily based on mental health. So we have mental health face-to-face actually higher in prevention in mental health, with 88%. Oh, I think, is my internet going? My screen has gone all funny. And there's also a significant difference between patients rating it higher, and this is across all specialities, than that of clinicians. But often clinicians that tend to report a lot of technical restraints compared to what patients do, but overall they were both rating it pretty high. Next slide, please. So as Alka said, we were working close with care homes, and it was quite interesting because early days we kept being informed that there was an awful lot of problems within care homes, and they weren't able to use it because of many reasons, as in there was no Wi-Fi or there was no technological literacy within them and nobody could do them. So I was quite keen to do a bit of independent research in this area to test it. And so we did 101 random interviews with care homes across all of Wales, just to understand the value yes, quite as important as I was told. So they told me that they had no Wi-Fi and they didn't want to do it, and most of the homes I spoke to didn't think that was the biggest of problems, that was for sure, and they were actually really keen and responsive to want to be trained up to use it. One thing did come out, that there was better awareness and better training was needed, in the sense that it was suggested that a single platform would work better, because an awful lot of care homes use all types of platforms like FaceTime and Zoom, whereas across the NHS, Attend Anywhere was the only platform being used, and that obviously then caused problems with care homes. So for example, a care home wanting to meet with a mental health practitioner, if they're on different platforms, then proved to be a problem. So a recommendation was put to the Welsh Government then based on this study to say that some kind of better linking and awareness into one platform would be effective. I can't see my screen, Alka. It's going really fuzzy. I don't know whether it's my internet.
I think you're breaking up as well.
Oh. Do you want to take over?
Okay. There's a video.
Oh, hello. Oh, hello. Where's Nana's big boy? Where's Nana's big boy? Oh, hello. Hello. Is it kissing mom? Where's Nana's boy?
Yeah.
Your mom?
You do as I do.
Yeah, not a nice dad.
Mary o ddi wrth 9. Dyn ni'n iawn?
So this was just to share some of the work we were doing with care homes. And I know Gemma's having some problem with her Wi-Fi. Gemma, are you able to carry on?
I think so. Every now and then the slides go a bit blurry, so I have to guess what it says, but I will try my best on guessing. So anyway, so another piece of work we've also been working alongside is a gorgeous pilot study called Ask Us About Dementia. And they've been using Attend Anywhere to deliver expert advice and signposting on dementia care. And they've been doing this pilot study, and so far the outcomes are looking very promising, and it's providing the opportunity to work differently using technology, is sharing learning across disciplines, quick access to advice, equity to access to specialists, and collaboration and joint working. And we've just started helping them do a robust evaluation on this, and we actually ran our first focus group today with the practitioners running this pilot, and we're also doing interviews with some of the patients and carers using it. So we'll have better understanding of how this is going. But based on today's focus group, it looks like it's been a very effective pilot study so far. And I know they're hoping to get some more money to take this and expand further. As Alka mentioned, she did a 3-month sabbatical last year within schools because she wanted to understand using technology within schools and linking up better with mental health, because based on the work we did in Cwtch and schools, that was one of our most favourite additions to the project, because the schools were just so responsive to it. So Alka did some work on this to look to link this up with the whole schools approach. So she was looking to bring some social health and social care into schools and into the communities. So she also conducted a school survey to understand what. Yeah, so anyway, so the future direction moving forward. So from 1 year's worth of understanding tele psychiatry across all of Wales has been very interesting. I think the suitability of VC, again, there's, like I said, there's no definitive conclusion of who it's more suitable for. I think there's certain areas within mental health which seem to be rating higher, such as follow-up appointments, medication reviews, psychotherapy, MDTs, that type of thing. Like I said, again, very little divide on digitally. That doesn't seem to be making any impact on age, gender, ethnicity, and so on. And it's been interestingly quite effective in areas like learning disabilities and autism, whereas one person will tell you it doesn't work at all, the next person will tell you it works fantastically. So like I said, no definitive conclusions. There are many confounding factors to why one thing works over another. And I think the assumption that grouping them into a social group and the digital divide isn't helpful. I just think, you know, representation is essential when it comes down to making these conclusions. And the problem being in research is often studies will go off and carefully select a sample of people to test this on. But we've been lucky here with this 1 year of national study, and we've been able to test the whole of Wales. And I think when you test the whole of Wales, it's easier to be able to break these myths down. And, you know, from my perspective, I think that's what we've been able to do with the use of video consulting, at least. Preferences and choice of using has been something we've also been asking within our evaluation, and it's been quite interesting. You know, the patient does get the choice, and the patient's more than willing to want it, but also there's choice made within the services to want it. And again, that doesn't seem to be a problem either. So as we're moving forward, we're making sure that we're running webinars and conferences and sharing good practice. We're now moving into phase 3, so we're forming really good relationships with academia and clinical expertise, and we're developing as we go in. And another interesting piece of work, actually, we haven't mentioned, is the virtual visiting that we're now starting. So we're bringing in using the Attend Anywhere platform that we've used within the NHS, and we're setting it up into hospital wards and learning from lessons that we learned from care homes. And we're setting up these virtual visiting rooms to be able to for families to be able to link in. And that is so far, so in these very early phases, but that is so far lovely. And I think a couple of findings that came out of care homes, as in like isolation and loneliness, similar findings are coming out from this virtual visiting. So it's a lovely step forward. So here's some of just a handful of things that Tech have developed over this last year, some helpful guides, toolkits. Here's how to use video consulting in secondary care services, and step-by-step and red flags, and it's very specific to mental health. And this is on our website, so if you're interested in downloading it, you can find this on our website under our resources. And that's it. That's my last slide. And one important point that we always try to point out is, as researchers, it's so important to start from the patient and work backwards. The patient voice is absolutely central to any program, any intervention, anything within the NHS. Thank you.
Thank you, Alka and Gemma. Because we are running over, I'll just pick up one question, and then how did you manage the cybersecurity and the GDPR challenges in this project, and the security governance, basically?
Do you want me to answer that, Gemma? I suppose we were partly lucky because we were on that path in terms of what we were doing, and we were using Attend Anywhere. We were lucky because NHS Scotland has been using the similar platform for 3 years pre-COVID. So we had a lot of learning and sharing of good practice from them. And Aaron Bevan, the health board where we work, this was very much embedded because there were a couple of projects working. So they had gone through a lot of red tape prior to COVID. So when we kicked off in terms of COVID, the DPIA, the equality impact assessment, some of those things had already been processed. So it wasn't starting from scratch, but it was just making sure, because again, with the pandemic, the guidance given was initially use any platform as long as, you make it safe and you explain to the patient what you're using. But I think in Wales, we were very clear that Attend Anywhere was something that was going to be supported by the Welsh government and encouraged as the only platform to be used. So that minimized all the risk around cybersecurity, GDPR, and other, information governance issues.
Thank you. That's very good to hear as a Welsh resident myself. That's excellent. I was also struck by the fact that Powys Health Board, which is quite rural, had a very good uptake of digital, the program. Anyway, thank you and Diok to both Alka and Gemma. Mm-hmm. And I'm handing over to Dave now.
Fantastic. Thank you, Alka. Thank you, Gemma. And thank you, Sandeep. Just also, Alka and Gemma, if you get the chance, there's a couple of questions there which if you have the opportunity, you might be able to sort of type the answers to. And also just to thank you guys who are still with us, 80 of us so far. I've seen a couple of emails already sort of expressing interest in the SIG, and I'm very new to Twitter, and the sort of closest thing I've seen to a Twitter storm this evening. So keep those emails in, do join us in the SIG. Please feel free to tweet us and follow us. Thank you for those of you who are doing that already. So now I'm going to introduce our third and final speaker, Dr. Lia Ali. So it's going to be a slightly sort of atypical introduction, because she's actually going to be talking to you about her sort of interesting and innovative career. So I don't really want to say too much about it myself, other than to say really that, you know, certainly as a trainee psychiatrist myself, I've been sort of quite interested by listening to people with different kind of sort of stories of career progression that involve sort of digital mental health. So that's what we're going to be hearing about now, where Dr. Lia Ali is a consultant psychiatrist and digital health strategist with experience in digital startups and advisory work. Is also an NHSx clinical advisor, is going to be talking to us about connecting, creating and caring insights from the world of digital health innovation. So over to you, Dr. Ali.
Thank you very much, David. First of all, thank you so much for inviting me to be part of this launch. It feels like an absolute privilege to be here. It feels like quite an exciting time. So I'm Lia, as David said, and David and Romy asked me if I could tell you a bit about my adventures in digital health innovation, how I've come to realise that I've always valued the importance of good design, and how addressing inclusion and inequalities have been a constant theme throughout that journey. I hope that by the end of my talk, you'll understand how I've always been guided by the principles of connecting and creating to provide the best care that I can. I think I've got a bit less than 30 minutes or so I was only going to talk for about the first 15 to 20 minutes, and then I'd really love to have a bit of a conversation, so I thought we could save the rest of the time for that. Please do pop questions into the Q&A, and let's try and make this as interactive as we can. Given that my story is also one of how I got into digital product design and service design, I thought of, instead of slides at this particular late in the day and inflicting PowerPoint on you, I'd tell you my story with a series of products. And the first one that I've got for you is actually this. So those of you who've gone into podcast mode now and have turned the video screen off, what I'm holding up is my daughter. I've stolen this from my poor daughter. It's a NASA t-shirt, and it's one of these flippy ones with this beautiful sort of sequin thing that you can flip up and down, so it's nice to touch, and it also looks lovely. If I had owned this as a child, I would have thought I'd gone to heaven, and that's because of what I wanted to do when I was little. Do you remember what you wanted to do when you were little? Answers in the chat, please. When I was little, I wanted to be an astronaut and a fashion designer. I thought I was going to be some kind of Vivienne Westwood meets Neil Armstrong love child. I loved colour, texture, and although I wasn't great at drawing, I used to spend hours creating outfits for my Cindy and Barbie dolls. I couldn't sew, so I was often fixing these with sellotape or stapling them together. And the rest of my time was spent thinking and dreaming about space, outer space. I'd been lucky enough to go on a family holiday to visit NASA in Houston, and I was completely smitten. We'd seen one of the earliest immersive IMAX film type experiences, a movie of a spacewalk, and I saw that famous image of the Earth rising in space, and it was rendered as far around my tiny little 6-year-old head could see. It will forever be one of the most beautiful images for me. But it wasn't just about the shiny rockets or the incredible engineering. It was always about the beauty that you could access when innovation is seen as the opportunity. As you can tell, I didn't make it into fashion design or into outer space, opting for a rather more conventional route into medicine and then psychiatry. But I never lost that appreciation for things that are designed beautifully or that evoke strong emotions, even if that thing is a llama. This is one of my many llama products. A few years ago, I noticed that llamas had been productized. They were everywhere. You might remember this. They were on funny birthday cards and internet memes. I mentioned it to my friends and family, and they basically laughed at me because they hadn't noticed this. But they did buy into the phenomenon and started buying me all sorts of products. So I now have this llama light. I also have a rather disturbing twerking toy llama that I felt was too much to inflict on you at this particular stage in the day. Something about this animal and the way it can be represented and lend its image just seems to connect with people and evoke an emotional response. Last year, this particular llama did something very special. He inspired the creation of a game that we ended up calling Happy Llama Cards. I had just started working as the head of mental health strategy at a virtual primary care company. Our head of product, Ruth, who I think might be in the audience today, knew that I wanted to learn more about the power of design thinking and its role in innovation. So she invited me to participate in a global virtual design sprint for charity. This involved spending my evenings after work over 2 weeks with product people like designers, user researchers, and sprint facilitators from as far around the globe as Mexico and the Netherlands. We took an idea around helping children suffering with mental health issues in lockdown through the design process to a fully functioning product that achieved its goals in user testing in just 2 weeks. This is exactly what I had been looking for since stepping out of full-time liaison psychiatry and integrated care service design. I've always been a doer, involved in frontline provision of care, service design and implementation. The Global Virtual Design Sprint allowed me to learn through doing. I was able to connect with incredible people like Ruth, non-clinicians who taught me how the creative process can be optimized to achieve good care outcomes, and showed me that this could be done at pace if the methodology is right. This only happens when you have creative people who really know what agile iterative working means. That learning had a much wider stage to play out on during my time working in the virtual primary care company. I built a digital-first mental health strategy to serve a large working population that was underpinned by foundation principles of a biopsychosocial approach, a logic of care, and an ambition to be digitally disruptive. I would hope I don't need to explain a biopsychosocial approach to most of this audience, but for those of you unfamiliar with logic of care, this comes from Anne-Marie Moles's work, looking at how patient choice alone will not achieve the best outcomes. In her Logic of Care book, she uses the example of providing blood glucose monitors to people with diabetes. The evidence base shows that the best outcomes in terms of blood glucose levels or end-stage complications of diabetes can only be achieved if there is a care element to that provision. For example, a specialist nurse who can match the nuances of a particular patient's disease experience, tailor it to their lifestyle and the tools available, and work collaboratively with that person to help them manage to adapt their diabetes management to their lifestyle. One of my concerns about the pace of digital adoption during COVID is the neglect of this logic of care. Don't get me wrong, as somebody who's been working in digital health innovation for a long, long time, the pace at which change has been adopted in the last year has been really exciting. But I am worried about this aspect of neglecting logic of care. It's in this situation that we are much more likely to see digital increase inequalities and worsen care, rather than be a tool to reduce them and improve outcomes, as I think it should be. This is particularly important as we move in healthcare to a phase of true digital disruption. I mentioned that digital disruption is a foundation principle for my work, so let me just pause to be clear with you about what I mean by that. A lot of the digital endeavours that we have seen over the last few years have been digitisation of existing processes that sit on top of a very traditional healthcare model. This is a service that is evolved from a model of healthcare that is relevant to the acute hospital, the bricks and mortar teaching hospital, and its traditional kings of acute medicine and surgery. COVID has forced everyone to face a truth that psychiatrists, GPs, and community health professionals around the world have known forever. The patient is only in our clinic room or in our hospital bed for a tiny fraction of their time. Their lives are out there, and technology means that we no longer as clinicians have an excuse to hold all the power cards and force them to come to us. This disruption was at the heart of patient empowerment through digital work that I was involved in at the Maudsley a few years ago. It's where I really got reacquainted with this product, brightly coloured Post-it notes, which we used as part of the design process for the patient-held record work we were doing there. I'll be honest, 6-year-old fashion designer me, wannabe me, was very pleased with this reintroduction of colour into my life. We had some incredible award-winning successes with that work, driven by beautiful narratives, such as the older man that we looked after with bipolar affective disorder, who had that very familiar journey of multiple admissions detained under section, often having become unwell after stopping mood stabilising medication and disengaging with mental health services. Whilst working with us, he tracked his symptoms digitally himself and spotted that he might be deteriorating, taking himself to his GP, whom he trusted more than his psychiatrists who detained him in the past, and getting his lithium levels checked. An even greater testament to the power of digital to integrate care while disrupting the system was that he had hypertension, and as part of our project was self-monitoring his blood pressure with a Wi-Fi enabled blood pressure cuff, resulting in him proactively seeking physical health help too. I think many of us will know the statistics around people with severe mental illness losing 15 to 20 years of their life compared to the average person in the population due to physical health morbidity and mortality. We owe it to our patients to co-create ways of achieving better care. And if it means changing the system, we should get on and do that. For me, this is an incredible example of how digital can reduce inequalities, but only if well thought through. I've taken this belief in the power of digital into a more recent, power of design into a more recent role at Thalamos, a company focused on digitizing the Mental Health Act to make it swifter, simpler, and safer. I still get to use my post-it notes, but they tend to be the virtual kind now, used on virtual whiteboards. That's progress for you. My understanding of the importance of design has progressed too. I'm looking at how we build in ethics and safety by design, so that this process that affects people at perhaps the most vulnerable point in their mental health care journey can be digitized in a way that, where possible, the experience is improved for the patient. For example, by releasing time to care, or by thinking carefully about design decisions that are made so that inequalities can be reduced and not perpetuated. This, for me, is what responsible innovation is all about. Just because the technology allows you technically to do something, it does not necessarily mean that you should do it. I've joined Thalamos because the team there have a genuine commitment to responsible innovation. And part of that has been the recognition of the need for service user involvement and for this to be real and meaningful, not just a tick box exercise. It's what I've started to think of as looking out for my VAL fam or value family. In other words, those people whose value set aligns with my own. I can give you a beautiful example to illustrate this. At the beginning of the pandemic, and before I was advising Thalamos, the issue of incorporating video consultations into Mental Health Act assessments was raised. Thalamos are lucky to have the absolutely brilliant Steve Gilbert on their steering group. Steve works as a serious mental illness living experience consultant and was also part of the Mental Health Act review. When video consultation integration was discussed last year, it was Steve who was able to bring to the table his perspective of having been detained under section and powerfully articulate why he felt it would be unethical to detain someone without an in-person assessment. The company took this seriously, despite very valid arguments around how in some situations, video consultations might have an advantage. For example, the thought of being approached by someone, an assessor in full PPE equipment, can be terrifying. Many of you will be aware that the law court relatively recently ruled that video assessments of Mental Health Act detention are not lawful. My work at Thalamos includes looking at compliance with clinical safety regulation as a clinical safety officer, but I can tell you that the regulation alone does not cover this kind of ethical decision-making. Last winter, I took the edX course in data, ethics, and responsible innovation, which I can highly recommend, by the way. It covered many industries and use cases, everything from the Cambridge Analytica scandal to police use of facial recognition technology. I learned a great deal about the importance of values-based design, including ethics by design, and it's where I heard Cynthia Dwork of Microsoft quoted as saying, "Design choices and algorithms embody value judgments and therefore bias the way systems operate." In comparison to other areas of health, I think we in psychiatry are more aware that clinical decisions we make do entail value judgments. As technologies become more sophisticated, as digital becomes the system embodying those decisions, we as clinicians must be cognizant of the way those technologies are designed, because those value judgments are being hardwired. That means, as Cynthia Dwork says, the system will operate with bias if the design choices have not been considered. For me, the opportunity within this issue is super exciting. I have always been passionate about psychiatry and particularly enjoyed that sometimes extremely tough role in liaison psychiatry of advocating for patients in physical health settings. I feel that I have the chance to continue doing this, but now through the medium of digital product design instead of solely in the clinic room. It feels like we are at a really interesting tipping point in our collective digital health journey, where we're beginning to see how good design and great user research and engagement can take us from technology as just a bit of IT support to beautiful digital systems. That image of the Earth rising in space comes into view for me. And of course, just as with the space program, it isn't all about the shiny tech. It's about the people, the skills, the infrastructure, the governance, and a culture that promotes responsible innovation. I believe that we in mental health services can be right at the forefront of this. In fact, we've already heard from Alka that we already are. My work at NHSx has been all about surfacing existing digital work in mental health to inspire others to drive forward digital transformation. We've drawn heavily on the work from the Global Digital Exemplar Programme, with some additions and updates from COVID work, covering everything from Aisha Rahim's advice and guidance work, joining up primary and secondary care, through to electronic prescribing, remote monitoring and mobile working, to the power of patient-held records and composable app service structures. I wish I could name check everyone who's been involved in this digital playbook work, because preparing the playbook has been an absolute privilege. It has given me an excuse to speak to the amazing people doing this digital work on the mental health front line, more of my value family. And I promise I'm not just saying these things because I know quite a few of you in the audience. I do, however, think that your collective digital thinking in mental health is underestimated by the wider system. All too often, I hear and see the acute hospital-based specialties given precedence in terms of engagement with technology and knowledge of how to drive digital transformation. Mental health is all too often an afterthought. That's one of the reasons I am so excited for the development of this special interest group. I really believe that this community, united by an interest in digital and a desire to provide the best care, can drive that agenda forward. So we're coming up to the end of our time together, and I'm still not a fashion designer and I'm still not in outer space, but I do think I have lived my values, some more than others. There is the importance of connection and building my value family around me. Secondly, I've discovered how much I value the space to be creative, and I'm definitely exploring what more I can do when I apply design thinking and creativity to my healthcare work. I've also learned what can be done when you operate at pace with the right team and the right methodologies around you. And finally, I've learned how innovation can help us care, especially when things get tough. Let me leave you with Steve Jobs' take on it. Innovation is the ability to see change as an opportunity, not a threat. Thank you. Very happy to take questions.
Fantastic, thank you, Lia. That's fantastic. Great talk with use of props as well. Just to let you know, there's many people in the audience who, well, maybe they are, but I'm assuming that they perhaps just wanted to be pilots. Plenty of budding fashion designers along with you, Lia. I think there's a almost professional diver in the audience as well. So yeah, I think for me, I think I wanted to be a taxi driver when I was younger. That was the main thing that I wanted to do. I loved sort of driving cars, anything to do with cars. So I'm going to go through some of the questions now. We've got a couple of questions on the Q&A, but I'd encourage any of you to type in some questions as well in the Q&A section if you want to ask Lia a question. We've got Dominic Stunning, who congratulates you on a very engaging talk and is asking if you've read a book called The Patient Revolution by David Gilbert and recommends that you do.
No, I haven't got that one. I do have many others. I did bring a few of the ones that have influenced my thinking. So there's things like this one, Health Design Thinking, that's the Bond book. And also this one is, but I will look up that one that's been suggested. This one is lovely. Information is Beautiful. That's the David McCandless stuff. And a lot of those have really inspired me to think about how we put across data, how we relate information to our patients and the importance of that when we're thinking about providing the best care that we can. And Romy, I'm sorry, the twerking llama, I will show it to you another day. It really is quite distressing.
Thank you for that. And I've actually got that Information is Beautiful book as well. It's really fantastic sort of display of information on it. So another question from an anonymous attendee. asking you, Lia, what did the patient involvement project at the Maudsley involve?
So that was patient health records work, so it's still going. It was called My Health Locker in the version that I was involved with quite a few years ago now. And it is, I think Barbara is around in the audience. So Barbara leads that at South London and Maudsley, Barbara Arroyo, and it's called Beth. And the original idea was around patient empowerment. So the idea being that if we give patients their records, the electronic health record is built around us, it's built around clinicians in an acute hospital setting. It's not built around patients. What happens when you give patients the record? What can you do with that? Is there a way? For me, what it embodied was an ability to disrupt the power dynamic within the patient-doctor, patient-clinician interaction. And there were a whole load of pieces of work, and it's moved on quite a lot. There will be a case study on it coming out in the NHSx digital playbook, which hopefully will be out fairly soon, from the SLAM work where it's got to now. And all sorts of bits of wonderful work you can do. There are other examples. Oxley's has been doing some of this work, especially in children and young people services. And some of you might have come across things like Patient Knows Best, which is a patient health record system that has been built around people originally with severe diseases, where you constantly hear that story in my work. And you will have, any of you who've done this kind of work with patients, people are sick of telling their story over and over again to every time they meet a new clinician. And this is one of the desires of people, is that they don't have to do that, that people are able to connect and share in their patient journey, especially when they have multiple providers, as so many of our patients in mental health do. We also looked, as I mentioned in the story that I mentioned in my talk, we looked at remote monitoring. And I know from Barbara's work that Beth has really come into its own in the pandemic with being a portal for access to virtual consultation. So this is the way I see things are going. We are going to have more of that position of the patient being at the center, and then all the different bits of that digital landscape we need being connected up in there. And it's happening. It's already happening elsewhere. So where I've been in industry for the last couple of years, I was working on systems which were a combined electronic health record and a patient health record. I couldn't believe it when I walked in there, having spent years trying to tell people that it was okay for patients to have access to their own records, and there being lots of cultural barriers, that it wasn't even a question. That was the way the system was built. That for me is real digital disruption, and that's where it gets really exciting in terms of us delivering care differently.
Fantastic. Thank you, Lia. I'm just looking, there was someone who was asking, I think actually she's a medical student, just asking in the chat if she's sort of asking to want to connect with you at some point afterwards to hear about your experience in digital product design and digital transformation. And in terms of a question for you to answer now, we've got Vivek, who is saying, congratulating you on a brilliant talk, and saying, how would you change people's mind about collecting meaningful data and not the useless information that bureaucrats ask for?
If you mean for clinicians to do that, you have to make it easier. And this is where the design part comes in. And I was thinking of this all the way through when Jenny was talking and when Alka and Gemma were talking. We do not pay enough attention to design and user experience and that user interaction perspective. If we did more of that, we would find ways to make it easier for this data to be collected. So I've looked at a number of things. One of the big sort of initiatives that I've worked with for a long time is IMPARTS, which is Integrating Mental and Physical Health Research, Training and Service, which is a King's Health Partners initiative. And my role in it was very much around the training part, but the concept of it is that when you're sitting in, so Prof. Matthew Hotoff was the academic lead, and his idea was that when people are sitting in the outpatient waiting room in rheumatology or dermatology, that while you're having your blood pressure and pulse checked, you should be having mental health vital signs checked. So PHQ-9, measures of depression, and GAD, measure anxiety. And that you could use these as a simple screening tool to highlight who is potentially having a problem with their mental health, and then training people to then surface those people into proper mental health care. And there are beautiful outcomes from the IMPARTS work. I strongly encourage you to go and look it up. It's also now has the SLAM part is called the Mind and Body Programme, and across KHP. And it integrates mental and physical health together, which is how we should be delivering care. Things like that when you have that informatics flow set up, people are healthcare assistants were trained to help patients fill out those forms on iPads initially in the waiting room. And then in the pandemic, it's actually switched over into being integrated into some of the appointment scheduling type tools. So where you'd get your appointment text, you might also have prompts delivered. So it's all about that user journey. How do we make this easier? And I can't wait till we get to the next step, which is already starting to happen, where we're starting to understand there are speech correlates, almost sort of digital phenotypes of PHQ-9 and GAD7. There's a company called Ellipsis which does this, and they are using machine learning and AI to analyze literally 2 minutes of speech, and you can get a proxy PHQ-9 and GAD7 measurement. That means that we're not having to do any recording of that. That means we're automatically getting those measures and being able to do that screening and then that monitoring of recovery. So for me, that's where the really exciting innovation is going to happen. It is making that flow easier all the time.
Thank you, Lia. I'm just going to put a couple of sort of quick fire questions to you now, because we're sort of running out on time. One of them is, are there any trusts that are already implementing PHRs? And someone else was asking, I can't remember their name now, how can clinicians get involved like you are with NHSx?
So on the first one on PHRs, yeah, there are quite a few. There's another lovely piece of work which not quite so much patient health records, but it's patient-based systems. So there's Bestie in Worcestershire. Again, all of these are going to be in the digital playbook, so that people can pick up quite quickly and see what's going on elsewhere. There are also bits of work going on here across other parts of health. So my role at NHSx is not just mental health, it's across health, and particularly long-term conditions care and integrated care. And for example, there's quite a lot of work in child and maternity health around PHR. So yeah, there's quite a lot of different places doing this. How can you get involved in NHSx? Well, I just randomly saw an advert actually in December is how I got involved. But they are follow on Twitter, follow on LinkedIn, have a look and see what things are going on. There are calls out, for example, the AI Skunkworks Lab put a call out for ideas, a Dragon's Den style initiative to surface ideas for AI within healthcare. So get involved with those sorts of initiatives. You'll find those on the Twitter accounts, the LinkedIn accounts. There are also things like the NHS Futures collaboration platform, which I would strongly suggest signing up to. You'll find more information about PHRs, electronic prescribing, AI, there are lots of different areas on that Future NHS Collaborations platform. Those are the ways that I would recommend getting involved with NHSx and what they're doing.
Great, fantastic, Lia. We're going to have to sort of end it there, but there's a couple of questions in the Q&A. If you do have the opportunity just to type in some quick answers, that would be absolutely fantastic. And just want to sort of draw things to a close now for the entire evening, and just to say thank you all for attending. And also what has been really great to see, and it's probably going to be the third time I'm about to say this now, it's great how I've seen you sort of interacting with us as the sort of panelists, and hopefully we've been interacting with you, answering as many questions as we can. As I said, I've been seeing lots of you tweeting and following us, writing emails and so on. That's really what we're sort of after with this Digital SIG, and that, that's sort of what's I think Lia is being excited about as well. We want to be a sort of engaging, interactive community. We'll be doing, as I said, future events. We'll be active in our website. We'll be creating a newsletter, but we're also really interested to hear your ideas, whether or not you're a member of a SIG, a psychiatrist, a doctor, a healthcare professional, a member of the public, someone who wanted to be an astronaut, whoever you are. We would like to hear from you, and we'll get back to you as soon as we can. Romy, I was just wondering, as the co-chair, is there anything else that you would like to say before we sign off for the evening?
No, that's great. I can't believe we still have so many people at 8 p.m. and you're probably hungry. So thank you so much. I think someone was asking maybe about if we could do something kind of collaborative or have a Telegram group. I think we'll give that some thought, because certainly we'd like to do something that people would like to join, and not just like a WhatsApp group where you'll all get spammed. So we want to think about it carefully about how we can create something truly collaborative. But please do get in touch. We'll be kind of making a sort of newsletter or online magazine, or however it will kind of formulate in the next month or so. So we'd love some kind of people contributing to that. So yeah, thank you so much to all the amazing speakers today. Like, I've learned so much, and hopefully we can kind of put some things going forward around digital inclusion where we're all working.
Great. Fantastic. Thank you to all the speakers. I'd like to echo that as well, and thank you for everyone who's attended. We hope to be seeing you again soon. Have a good night, everybody.